in their Work Together program, which aimed to improve palliative care services for residents living in our aged care homes. At that time, we had a residential portfolio consisting of 12 homes located throughout metropolitan Melbourne and regional Victoria, and all 12 homes participated in the program. Each of our homes provides care to residents from a range of different cultural and religious backgrounds with varying degrees of clinical acuity. At VMCH, we provide palliative and end-of-life care that is underpinned by clinical best practice guidelines. We have a palliative care approach that is multidisciplinary, resident-centred, holistic, educational and collaborative. And at the time that we partnered with ELDAC, as an organisation, we had identified a number of other key areas that we really wanted to further develop and focus some energy on. Those 4 areas included advanced care planning, looking at strengthening the relationship between our aged care facilities and the local external specialist palliative care providers, upskilling our people, and being better at identifying clinical deterioration. So as we know, in essence, advanced care planning is designed to ensure that clinical and end-of-life care for residents is provided according to their values, wishes and beliefs. From our experiences, we also know the importance of ensuring that there has been consultation between residents and their families as to what is outlined in those advanced care plan directives, as this really helps avoid any confusion at a later time when decisions need to be made regarding care and management. Now, at the time of our involvement with ELDAC, approximately 40% of our resident population had an advanced care plan directive in place. So in a bid to improve this, VMCH deployed a number of different strategies. Firstly, increasing awareness. So this was targeted at residents and their families to really understand the importance of having an advanced care plan directive in place. And we achieved this through marketing and communication, through platforms such as social media, newsletters, and having on-site resident and relative meetings. We provided staff education on having the conversation around advanced care planning, and we delivered this education both online and face-to-face. We reviewed our admission process because we really understood the importance of having the conversation early about advanced care planning, even at the point of entry into aged care. We also reviewed our clinical handover process so that we had streamlined communication between the aged care homes and other key stakeholders, such as ambulance services, hospital in-reach, GPs, and palliative care service providers. At VMCH, we are aware that not all of the residents entering our aged care homes have the capacity to complete an advanced care plan directive. So in response to this, we developed our own medical goals of care form. This medical goals of care form is a simplified one-page document that has preferences around resuscitation, hospital transfer, and life-prolonging treatments. Now, this medical goals of care form is completed by the GP and the resident's nominated substitute decision maker. And finally, at VMCH, we recognise that not all residents and families wish to have an advanced care plan directive or a medical goals of care form completed, and we respect these wishes and make sure that this is noted. Overall, VMCH has seen a significant improvement and increase in the number of advanced care plan directives and medical goals of care forms being completed across all of our aged care services as a result of the work that we've done in this space. The next area that we wanted to focus on was really strengthening the connections between our aged care homes and those external palliative care service providers. Given that our homes are located across a range of different geographical areas, the first thing we needed to do was identify the local palliative care service provider. Once we had done that, we arranged a meeting with them to further understand their service delivery model and to also understand their referral pathways. We then established monthly clinical palliative care review meetings, and these were conducted on site and attended by clinical staff from the home and also representatives from the palliative care service provider. The objective of these meetings was really to provide an opportunity to network, share information, discuss new referrals, and also any complex cases we may have had on site. Our experience was that some of the palliative care providers were really engaging right from the beginning. However, the relationship with others sort of evolved as we worked through the program. However, where we are now is that all of our VMCH services have really strong working relationships with those external palliative care service providers, and we continue to lean on them for support. In addition, all of our staff are much more familiar with the roles and responsibilities within each of those services and the referral pathways. At VMCH, we understand the importance of ensuring that our people have appropriate and targeted training on palliative and end-of-life care, and this is not just exclusive to clinical staff. At VMCH, we believe that all staff have a responsibility to ensure that our residents are receiving quality palliative and end-of-life care. We have a dedicated palliative care resource page on the VMCH intranet, which houses all of our internal policies and procedures, and also provides evidence-based practice materials that all of our staff can access. We have an internal learning and development team who are responsible for facilitating a number of palliative care workshops for our staff on topics such as pain and symptom management, continuous subcutaneous infusions, and emotional and psychological interventions for residents who are dying. At the time of our involvement with ELDAC, we were fortunate enough to engage a palliative care nurse practitioner, Regina Kendall. Regina also conducted a number of workshops for our staff, and she also facilitated reverse pepper placements for 3 of our aged care homes, which was really pivotal in helping staff consolidate their knowledge. And finally, clinical deterioration. Our experience showed that a number of our residents were being transferred to hospital unnecessarily, where we could have managed their care much better in the home. And some of our staff were delaying referrals to those external palliative care service providers. So in response to this, VMCH developed a stop and watch tool. And the purpose of this tool was to really help identify early signs of clinical deterioration so that we could initiate appropriate interventions and have consultation with those key stakeholders, such as GPs, hospital in-reach services, and the palliative care service providers. The stop and watch tool was rolled out across all of our homes and supported by internal policies and procedures and staff education. What our regular monthly data shows now is that we have seen a significant decrease in the number of unplanned hospital admissions for our residents, because our staff are being better at identifying clinical deterioration and initiating those appropriate referrals and interventions. So where are we today in 2003? Palliative and end-of-life care is core business for us here at Villa Maria Catholic Homes and is underpinned by our organisation mission and value statement. As a Catholic organisation, we are also fortunate enough to have a really strong pastoral care practitioner presence across all of our aged care services. Our practitioners are pivotal in providing emotional and spiritual support, not only to residents and families, but also to our staff and wider community. Since participating in ELDAC, VMCH has expanded our residential portfolio to include a palliative and comfort care facility. In 2021, O'Neill House in Prahran opened and is a 22-bed facility exclusively for residents requiring end-of-life and comfort care. O'Neill House is linked very closely with Cabrini Health Specialist Palliative Care Services and Dr. Natasha Michael and her team. We're fortunate enough to have a dedicated medical practitioner, Dr. Mark, who specialises in palliative care, and all of our staff have had appropriate training. So I think as an organisation, when we look back at our experience with ELDAC, it has definitely been a positive one and helped strengthen our palliative care service delivery model to ensure that we're providing high quality care for our residents across our residential aged care services. Thank you.
Hello, thank you for that, and apologies also for just starting the recording just after you began. That'll be a little bit annoying for those picking up later. I've got a couple of questions that have come through, but I will leave those till the end. So Natasha, if you're able to turn yours on, if you turn your camera on. Yes, we will be able to access those slides. We'll be sharing them on the CHA website. So Natasha, if you turn your video on,
I can't because you have blocked my video. You've got to unblock my video.
I don't know how to do that, so I apologize for doing that. So what I'll do is I'll share the slide.
You can just share my slides.
And then I'll figure out how to do that as we go. So more technical issues. Okay. So
that's
if
all
I
right.
do the share screen here.
Can I just check, Jason, how much time do I have so I keep to time?
We've gone 15 minutes of 45 minutes. So if you can go about 15 or no more than 20 minutes, we'll have time for questions.
Wonderful.
Excellent.
Terrific. Hello, everybody. I'm Natasha Michael. I know some of the names that have registered, and welcome to those of you who haven't. And we started today with the acknowledgement of country. I thought I might also state that last week was the feast of the canonization of Mother Cabrini. And for us at Cabrini, that's an important thing to remember. Mother Cabrini is the patron saint of migrants, and many of us care for migrants in our individual organizations. So I'm going to follow through a little bit from Naomi. For those of you who haven't visited O'Neill House, I suggest that you do. They meet the criteria for a level 2 level 2 palliative care service, not a level 3 service, and they provide an extraordinary service really to the community. So what I'm going to talk about today is really how we take things a little bit further from what Naomi was talking about. So we talked about advanced care plans, we talked about upskilling our staff, we talked about preparation of patients and families, but I'm a clinician researcher. So the way I look or foresee things might be a little bit different. We know that on average, people only complete next slide, please. Only about 30% of advanced care plans are completed. So the data that Villa Maria has is very correct, 40% uptake, higher in aged care compared to general populations. So Cabrini runs an integrated palliative care service. We used to have Cabrini Paran. That's now shut until we build our new units. So we are based on a ward in Malvern. We have a large integrated service with a community ambulatory consult services with external partnerships and referrals. We work very closely with Eastern Palliative Care, Mercy Health, Banksia, and Villa Maria, as well as Calvary and Melbourne City Mission. We run a model of early integration, meaning that because we have large cancer services in our hospital, we see patients very early on in their illness and not just at the end of life. So sometimes people are on our community books or on our clinics for a year or two even, and sometimes we discharge them. Okay, so I'll let you move on to the next slide, please. So we're going to talk about three things today. The first is this concept of values. We speak a lot about advanced care plan and the importance of considering patient values. And what does that actually mean? The second thing is to explore the concept of concordance in care, and I'll talk to that in greater detail when we come to the slide. And the third, I think, which is the most important thing to consider, not just in our work in palliative care, but also in the Catholic health space, is how we explore and how we respond to suffering. Okay, next slide. So what are values? Values are, if you look at the definition of values, they are individual concepts of our desirables and our overarching philosophies that guide our attitudes and behaviors and priorities in life. And the thing that we all fail to recognize sometimes, that individual values are determined by many things: culture, life experience, religious belief, societal influences. A good example would be that this concept of talking about dying or completing advanced care plans. Many cultures or societal or ethnic groups don't want to do that. that, right? And when you force something like that, what Naomi was correct in saying that they offered people the opportunity, but when you force something or you use it as a benchmark for performance, you're failing to recognize that something might actually be against somebody's innate values, okay? So does care improve if we seek to understand personal values? And I'm just going to share with you a small bit of my research that I've done recently, where I made videos to help people understand what I was talking about when I said to them, think about your values, okay? So the next slide you're going to see is a video that I made as part of a research study where I was trying to encourage patients and their caregivers to talk about what was important to them. And I tried to get them to mirror what was being shown in a video, okay? You've got to turn your volume up.
It's a bit disappointing that the scans have shown that the cancer's come back.
Certainly is, yeah. But look, you know, I'm going to be here to support you. And we've got Andrew to back us up.
And look, and I guess that we really have done a lot of things in the last 2 years. You know, we've downsized with the house, and that was hard to begin with, but I think we're really happy with what's happened there.
Well, we managed to get some travel in as well.
We did, yeah. And those couple of holidays we had with the children were just fabulous.
Lovely.
Yeah, I mean, it's...
And the grandchildren are closer to us now.
You know, I was thinking about that. In some ways, this has brought us closer together.
Right.
Because we've had the discussions, and they've been so important, those discussions. I've probably felt closer to you than I have, you know, for a long time. I think
we can stop, Jason.
I'd like.
Terrific. We can move to the next slide. So what I was trying to show you there really was, you know, there's something to be said about giving somebody an advanced care plan and saying, I need you to fill this and think about what's important to you. But when people come to me in clinic, what I really want to achieve is to get them to really think and communicate in the way that I've demonstrated. Those were two actors, and we spent a lot of time training them. So I did a little study where I gave people the video to watch, or I got them to just do an advanced care plan as usual. And it was what we call in research a negative study, in the sense that I did not increase the number of advanced care plans that were completed. But what I showed was that older people were more likely to complete them, right? That the video talking about dying made people distressed, and that is normal, right? The worrying thing that I find now is ethics committees reject studies because they don't want to upset patients. But difficult conversations upset patients, right? That's normal. The important thing is that the upset is not pathologicalized and support is provision. But people like the fact that they were given the opportunity to talk about these things. And most importantly, ours was the first study to show internationally that advanced care planning conversations or care planning conversations improved concordance. Okay, so let's give you the next slide now. So what is concordance? We don't talk enough about concordance when we care for patients. Concordance is when you seek to reach an agreement between the patient, clinician, and actually I should also say family in that definition. It's what we call triadic concordance about the best treatment and care decisions compatible with what the patient is desiring and seeking to achieve, okay? So does it matter if you complete an advanced care plan, but your concordance between the patient and the carer is not there, right? And concordance is really important for a number of reasons. It helps families function. It reduces stress in relationship. It's been shown to really seriously improve bereavement outcomes. It's affected by socio-demographic factors, and longitudinally, we understand how concordance affects communication. So those two circles are drawn by patients when we ask them, tell us how you think that conversation between the patient, the doctor, and your caregiver looked. And you can see, I mean, I can give you 6 other examples of circles of how patients perceive concordance in communication occurs, okay? Next slide, please. I don't think we have time for the next video, so we might just skip it because I'd rather take questions. Yeah. So the next video, actually, when I put it on the system, you can watch it. It demonstrates two brothers talking about putting an NG tube in and going to ICU, and they reflect on the memory of how their mother died. And that enabled this younger brother who had cancer to make a decision about what was important to him. And they were achieving concordance, right? This is what I don't want. Well, this is what maybe you should think about. How do you get these people to come closer? So when you think about concordance in communication, you really ultimately want to achieve goal concordant care. You can fill in an advanced care plan, you can fill in a goals of care communication form, but if you don't achieve concordance, the people who are left behind, the families, etc., are at risk of significant outcomes that are negative. Okay, go on to the next slide, please. The next slide shows you something else that we found in our research here at Cabrini when we looked at people who completed advanced care plan, and we looked at what they had written in their values directives. And what we found was people were able to posture both vulnerability and resilience. Okay, so we have a tendency in health to label people to say, oh, they're too stressed, they're refusing to go home, the family won't cope. We don't enable the points of vulnerability, of resilience. So when young doctors come and say to me, I don't think the family will manage at home, my question is, have you explored all the ways they potentially could manage, right? I don't think this patient will cope with going into an aged care facility. Well, have you considered talking to them about what's positive about an aged care facility? So people were able to acknowledge their frailty, but also talk about this concept of acknowledged dependence, right? I understand that I have to be dependent on my caregiver, right? They were able to talk about the fear of dying, also ambivalence and their acceptance of dying, all in the same conversations. They were able to accept all of these things. They could be frightened, they could be accepting, or they can be ambivalent, but they sought meaning, right? And they demonstrated vulnerability. They were very importantly, I think, open to this concept of benevolence and reciprocation of family and friends. So when people tell me about, I'm worried about burdening my family member, I always talk to them about the importance of the act of benevolence and reciprocation. For all you did for your children, sometimes it's important to let your children do something for you. It's important for your grandchildren to watch their parents care for you. Our job is to do everything we can to support you, right? So what do we do in aged care? Do we allow families to come in to assist with feeding? Do we encourage them to assist with washing, turning, minding? These are important acts of benevolence and demonstrates reciprocation, okay? And then they talked about the importance of honoring death through both secular and sacred rituals and traditions. Okay, on to the next slide. So when we die, it's a very lonely process. You might have 20 patients around a bed, but the process of dying is a very individual process. And increasingly, we talk about this phenomenon of existential distress that we explore: hopelessness, feeling a burden, loss of dignity, a desire for death, a will to live, and threats to their identity. Existential loneliness is this intolerable emptiness, sadness, and longing. Yeah, okay. Really from the fundamental premise of us being vulnerable human beings. Next slide. So if you just press the buttons for me, Jason, until the pictures come up. So a great example of why existential distress, next slide is, next button is important is because of the current legislation, and next button of voluntary assisted dying. And you can see the main reason in Canada, the nature of MAID, M-A-I-D's Canadian data tells us that the main reason people seek voluntary assisted dying is the loss of meaning in life, the loss of independence, and inadequate control of pain is always cited, but it's not the most common reason. Okay, next slide. So one of the things we have to work really hard on in our care facilities is to help people who face these problems, face these challenges of understanding their values, making sure that their values are recognized and their distress, is to help them heal. Because healing is wholeness. Yeah, we think of it as being in the pastoral care practitioners in charge of healing. But in order to heal, we have to help our patients and our clients really heal their soul in their preparation for their dying. Yesterday, a 92-year-old man told me about the 3 rabbis he had interviewed, that before he picked who was going to officiate at his funeral. I thought it was a wonderful way to prepare, is to interview your pastor or your rabbi. Next slide. I just want to try and keep to time. So suffering, we know from Eric Castle's world, is the distress that we associate with things that threaten the intactnesses of our being. And death is one of them. Next slide. So in order to ameliorate suffering, we have to be a healing presence. Yeah. So we are conscious and compassionately present in the moment with another, believing and affirming their potential for wholeness wherever they are in their life. Next slide. So you can't do healing presence, you become healing presence, and that's a conscious act. Yeah, listening, holding, talking. Silence is one of the most important things to do. Being still, slowing down, appreciating, forgiving, humbling, and kind. So it's not uncommon for families to be angry with us or patients to accuse us of things, and our mistake is we take a defensive role. Right? And we list all the things we did, and I never said this, I never said that, etc. We forget actually the more appropriate thing to do is actually to listen, to get into the space, to forgive if we did something inappropriately or they have reacted inappropriately, and we come to a situation with some level of humility. Okay, next slide. So healing presence in our work is critically important in our Catholic space. It's the essence of what we do. Because when we are truly present to another, we alleviate loneliness. We affirm the authentic self of a person, and we invite a presence of wholeness. We allow for spiritual presence and bonding. We bring together a sense of our common humanity and the acknowledgement of another as a person. We invite all of us to transcend ourselves and our own limitations, and we become more reflective and we think more deeply. So I always share this story of this photograph. In my first palliative care job, I was 26 or 27 years old in the west of Ireland. And one of the things I encountered was a lady whose husband died of pancreatic cancer overnight, and she slept with his corpse in the bed over the night. I didn't understand it. I was too young, and I thought it was the most gruesome thing ever, until I went back for a bereavement visit and she showed me this photograph. And this photograph really said everything there needed to be said, really, about why she did what she did. It taught me a great lesson, really, about what occurs at the time of loss for families or carers. One of the questions I always ask elderly people is, how long are you married, or how long were you married for? It gives you an understanding of relationships and loss that people endure. Okay, so I'm just going to end there, and I just want to circle back to what Naomi has said. So some of the things Naomi talked about were critically important about some of the structures and processes that we put in place to enable care. But we have to think a second level. We have to think more deeply about why we do these things. And more importantly, if we are organizations that are, whether Catholic or not, but if we are committed to palliative care, we need to understand the deep essence of doing what we do really well. Okay, thank you very much.
Okay, well, thank you very much. I certainly felt a lot of those presentations, having been with my parents as they both went through their journey. Very similar. That photo at the end was that hit, going through a lot of the photos of my parents at the end there. We do have a number of questions. I think I know who they're for, but also please feel free to keep throwing more questions into the Q&A or the chat. either put your name on it or come up as anonymous. If it's anonymous, I have to read it out. You might have a better spin on it, but I think I'll start. I think this one's for Naomi. How did you engage non-clinical staff on the change journey? And how did you connect non-clinical or non-care staff into understanding where they fit in the experience?
Yeah. Look, I think VMCH have a really robust orientation and onboarding program. So all new employees to VMCH really, I guess, have an understanding of our position and the importance that we place on, palliative and end-of-life care for our residents. So we outline those expectations, I think, straight from the beginning and during that interview process with potential new employees, because we want to make sure the fit is right, not only for the staff member, but more importantly for our residents. Obviously, and I spoke about that earlier around having a really robust education and learning program in place. So that really helps increase staff awareness, around palliative and end-of-life care. And as I said, we've got an on-site learning and development team, but also have a really extensive online module around palliative and advanced care planning and all things end-of-life, which all of our staff, clinical and non-clinical, have access to. Each of our homes have a daily huddle. So every morning there's a huddle which consists of clinical and non-clinical staff, where we sort of outline what's happening for the day, but also discuss any residents who may be declining or on that palliative care approach. And I think it's really important that, as I said earlier, it's not just about the clinical side of things, but all of our staff have a responsibility to ensure that our residents are receiving that quality of care, that we're present, and that we're all working towards the same goal. And I think at VMCH, we really do encourage that home-like environment. And a lot of our staff members, clinical and non-clinical, have been in the services for a very long time. And you automatically develop that sense of attachment to our residents. So I think for our staff, clinical and non-clinical, we want to be part of that journey. And I think that's the sort of where it stems from in terms of our staff culture.
Okay. Got a couple of questions about cultural backgrounds and family. I might start with one about family and come to the cultural dynamics one second. And this is open for both of you, and maybe Natasha, start. How do you navigate various family dynamics as part of your palliative care delivery at site?
Yeah, family dynamics are tricky, right? And I always say to families, I only worry when I meet the perfect family. When the Waltons come in to see me and everybody loves each other, all my radars go up, because usually I open a cupboard door and all the skeletons fall out. Most families function within dysfunction. That's normal. Okay, so when families come to see you and there's conflict or challenges, the first thing you've got to do is really acknowledge that all of their worries or concerns or anger is okay. It is normal to feel this way, right? You don't pathologicalize something. The second thing you've got to say, if conflict occurs between family members, once again, that this is not unusual. So a very good way to alleviate family issues is to have a family meeting. Yeah. And in many instances around the end of life, you must have multiple meetings. So trainees or young consultants come to me and told them they're not getting it, right? Well, they'll tell you, the data will tell you people only retain 30% of the information. So you have to have multiple meetings, okay? Ask people to come in with questions before they attend their meeting, yeah? Make sure you prepare for a meeting. And I can send an article to Jason to distribute around family meeting styles. We encourage something called circular communication rather than direct communication. So people I don't say to somebody, how are you coping? How are you feeling? I say, if there's a family, how do you think your brother is doing with your mother's situation currently? So you invite alternative perspectives. So there are techniques and skills that can be learned and should be learned. And I think if you ever are dealing with a difficult situation, take your gloves off, right? And very, very, very seldom do I have to avert to the law or legal processes. Yeah, usually they are resolvable.
Anything
And
to
I think
add?
from our perspective, you know, at the point of entry into aged care, we really like to identify who that nominated representative is, or that substitute decision maker, because as Natasha's touched on, you know, sometimes there is family dynamics and there's a family of 6 or 7 siblings and they don't talk to each other and there's a lack of communication. So from our end, it's really trying to identify who that point of reference will be from the facility's point of view, so that we're not making multiple phone calls and there's no information being lost in translation. So we have that conversation very early on. There's documentation around who that person is, and as Dr. Michael spoke about, it's around those regular case conferences. That's something that we really facilitate at all of our homes, irrespective of if the resident is receiving palliative care, so that we're being very transparent and there's no information again being lost. So yeah, I'd agree with everything.
Okay, I'll ask 2 more of the questions that have come through, and just note for the person who asked about some top tips, I'm actually going to put that to the presenters separately and add those notes to the website. So I'll answer that later. But I think really picking up on the family dynamic site and now going into the cultural differences, and I think the cultural differences can exist within families, but also with staff and the patient and their family. So there's multiple sort of areas there. So maybe start with Naomi on that one.
Look, I think, you know, in today's society, you know, we appreciate that we have residents from a range of different cultural and religious backgrounds, but we also have our staff from a range of different cultural and religious backgrounds. And again, I think it comes down to one of our values at VMCH, and it's around respect. So it's just that mutual respect and understanding that we do all have differences, and it's about embracing those differences. And again, it's an education piece. I mean, we're always learning, even myself personally, around different cultural requirements, you know, during that dying process and after that dying process as well. So it's really making sure that our staff are familiar with those different practices. And even though it doesn't align with their own individual personal values, it's about having the emotional maturity to understand those differences and to have that level of respect.
Natasha, anything to add?
Yeah. One of the key things that you must be curious when you work in health, it must be in health, is be curious, right? You must be wanting to know and wanting to understand. So a simple thing like, tell me about what you do in your Greek community, etc. That's a good one point. The other thing is to engage. There are many, many groups like the Chinese Cancer Society, Peronia with the Greek community, the Italian support groups. Engage these external organizations when you have people in your organizations of those different groups. The third thing that I always challenge people to do, I grew up in a multicultural country. As a child, I had visited temples, Buddhist temples, Hindu temples, mosques. They was a second nature to me. Right? If I ask many Australians, they haven't done that. And rather than sending your exec or your managers out, send your staff on the ground out, right? So we're going to do a field trip this Saturday. We're all going to go to the local synagogue or the Jewish Holocaust Museum because we care for a large number of Jewish patients. It's a wonderful way to build a team, but also a great way to really expose people to what it is, how and where people come from. So trying a variety of different approaches is important. Yeah.
Okay, and now my first time trying another thing. I'm going to try to allow Michael Priest from the Catholic Archdiocese of Port Pirie to talk. Let's see how I can go. Give it a go, Michael.
Yeah, thank you. I just sent a question about our aged care facilities. The staff that work in them are so busy and sort of run off their feet. And I think when you were talking about healing presence and how important that is, I wondered about and then the restrictions of visitors and volunteers of late is a problem as well. So I was just wondering whether you might have had any suggestions about how we can provide that healing presence to our people in aged care.
Yeah, thank you, Michael. That's a really good question. And it's a lesson I learned many years ago. There's a man called Michael Carney, who was an Irish palliative care doctor, then subsequently worked in Santa Barbara. He wrote a beautiful book called Mortally Wounded. And he says our task really is to create a place where healing can occur. And when I was a trainee, I worked with some of the most extraordinary senior doctors in palliative care. And what I learned was you can create a healing presence just by being at the bedside of somebody for 2 minutes, right? So I have a rule. When we enter the room, we're not allowed to bring in medical notes when they're around with me. You have to sit on a chair, right? And you have to be curious about what's on the bedside or photographs on the wall, etc. So you're demonstrating interest in the patient and not the person and not the patient. So when after death, we get a lot of thank you letters and cards. And I'm quite amazed at the number who mention our domestic staff, the cleaners, the person who brings the cup of coffee, because it's not the transcendent conversation that you have and you pulled up a chair for 30 minutes, right? It's the person who was just attentive and fixing the bed, pushing the glass of water closer to them, offering a sip when a patient can't reach. Those simple acts of humanity are sometimes the best healing presence that we bring. And busyness, we portray busyness in the manner in which we present ourselves. We can be very, very busy, but not portray busyness, if you know what I mean. Michael?
Yeah, that's a great answer. Thank you.
Easier said than done. Yeah.
Naomi, anything to add to that one? Or
No, I don't think I can add to that. Thank you.
That does speak. I know staff have had a lot of time taken up. There's a lot of new requirements coming through, new training, and I think it's really important that we can take the time to listen but also to try to give our staff that time. So it'd be really interesting to see how we go. I'm going to cut off questions there. There's, I think, still a great attendance holding on at the end of their lunch break. Thank you very, very much to the presenters today. I really enjoyed it. I enjoyed most of it. Other parts are a little bit too close to home, but it was really great to hear. So thank you very much. I'll remind everybody that there's a few more of these to go. The next one's on Tuesday, August 15. Professor Liz Redmond from Queensland Health will be presenting on increasing palliative care capacity in residential aged care facilities, but also home-based palliative care as well. So that will be a very practical sort of hands-on presentation, and I look forward to talking to you then again. So thank you everyone for attending, and thanks again to the presenters. That was great. Thank you.